Hi, this is Brian Wormers providing a lecture on biliary system and pancreatitis for medical surgical nursing at the University of Sioux Falls. Some of the learning objectives that we'll talk about will be cholecystitis, pancreatitis, and we'll talk about the Whipple procedure. So cholecystitis is an inflammation of the gallbladder. It can occur with stones called cholelithiasis, or it can be without stones. And so that would be more of a biliary stasis type of situation. What can happen with this one, the gallbladder wall may perforate, and then of course as you're getting bile salts throughout the peritoneum, then you're going to get peritonitis, because the role bile salts do is to break things down, and that's not good if it's free floating within your peritoneum. So manifestations include jaundice, icterus, pruritus, flatulence, dyspepsia, eructation, anorexia, nausea, vomiting, abdominal pain, especially when it's surrounded by ingesting fatty foods. They might get some biliary colic as that stone is going through, and so when it's causing obstruction and it's grinding along the way, of course that's going to cause signs and symptoms such as tachycardia, pallor, and diaphoresis. You might see Murphy sign, which as pain increases with deep inspiration. You might see Bloomberg sign, which has got some rebound tenderness of the abdominal. And you might see some steatorrhea, and these are fatty stools that are often clay in color, and it's because the bile salts are not breaking down the fat. Diagnostics, so CT, ultrasound, hydroscan, which is nuke-med, endoscopic retrograde cholangiopancreatography. They also have MRCP, which is an MRI version of this, so not using the scope but just looking at it with MRI. Nutritional therapy, so we want to try and keep a low-fat diet, fat-soluble vitamins, bile salts. So if you're not breaking down fats, you're not getting fat-soluble vitamins, so we might have to supplement that. Drug therapy, so pain medications such as morphine or hydromorphone. I've heard hydromorphone more commonly used because if you get spasms at the sphincter of Oddi, you can cause some of this cholecystitis. And so sometimes the hydromorphone's got the side effect of opening that up, and that can help out that way. But other things we'll do, anticholinergic drugs and antiemetic if they're puking. We can treat the stone with lithotripsy, so giving those shock waves and breaking up that stone so the person can pass them. With the ERPC, we can sometimes go in and grab the stones. Otherwise, sometimes we do have to do surgery and grab the stones that way. Pancreatitis, so this is inflammation of the pancreas and the surrounding area. So enzymes are activated in the pancreas rather than the intestine, and you can see why that would be problematic. As it gets necrotizing of that tissue in the pancreatitis or in the pancreas, symptoms are more severe. Can occur with alcohol or fatty food ingestions, but are going to vary widely. But generalized jaundice, steatorrhea, Cohen sign, which is bruising around the belly button, gray Turner sign, which is bruising around the flanks. Bowel sounds might be decreased because you get increased fluid in your stomach. Abdominal tenderness, rigidity guarding, Kerr sign, which is that left shoulder gets some pain. Nausea, vomiting, pancreatic ascites, vital sign changes in lab with your glucose, because this is where we make your insulin. And so if your insulin sites are destroyed, you're not making it, and so you might see a bump up in your glucose and then your liver enzymes. So we do want to manage pain. Lots of different ways to do that. Like I said before, we can talk about morphine or Dilaudid, and that might help out more. Other things we can do, ERCP, and go in after the stones using a scope. We can use surgical and do it open or laparoscopic. And then if they're not producing insulin, of course we need to give some insulin. Now, if the pancreas and the biliary tree is not working correctly, what we might do is just reroute things a little bit and then hook the pancreas directly up into the jejunum and then have that be part of your biliary tree. And then the food from the stomach will come in at this angle, join up here, and then go through the small and the large intestine as before. but you're just using this part of the jejunum as your biliary tree to connect the gallbladder and the pancreas. Alright, that concludes this lecture on the biliary system and pancreas. If you have questions, please contact me.